Good afternoon. On behalf of the Department of Pulmonary, Critical Care and Sleep Medicine at the All India Institute of Medical Science in New Delhi, I welcome you all to this clinical grand round today on by our department. Basically, this event is there on every week, and this time we'll be presenting our grand round. What we thought was, in this particular pandemic in which we have been grappling with this situation for last so many months, we discussed and we thought it was apt that we also present our perspective of the COVID pandemic as we have seen it over the last couple of months since it began. Hence, we'll be talking about the COVID-19 as we have seen it unfold and the journey so far, and also incorporating a little bit about the patients and the work that has been done, the data that we have, the research activities which are going on also, along with the clinical perspectives. And this is the overview of the grand round that we are proposing. We'll start with the overview of the clinical management as it is as of today and how it unfolded, and that will be taken by our director, Professor Randeep Guleria. This will be followed by a talk on the management of severe COVID, which is the one which is associated with the highest mortality. So that is of great concern, and that will be taken by Professor Sushma Bhatnagar, who is the head of our Department of Onco-Anesthesia and Palliative Care Medicine. Followed by Dr. Pawan Tiwari, who is our assistant professor, who will be showing the patient profile of the patients whom we have seen over the last 7-8 months at AIIMS, and especially the Jhajjar Center at the National Cancer Institute, followed by a few ongoing research and publications in this field which has been done or which are ongoing by Dr. Saurabh Mittal, who is my colleague and assistant professor in the department. And then we'll be wrapping up with a short brief overview on now the post-COVID and its recognition and management, which is also becoming an important clinical entity as the pandemic unfolds. So I'll start by inviting Professor Guleria to come and start with the overview of clinical management of COVID-19.
Thank you, Dr. Nadmohan, and I shall basically provide a broad overview to set the stage as far as the grand round is concerned. So when we look at the definition of COVID-19 has evolved from what it was in the beginning, which was focusing on people coming from outside or travelers coming from outside. Now it's basically a patient with acute respiratory illness and a history of travel or residence in a location reporting community transmission of COVID-19 disease during the last 14 days prior to symptoms, or a patient with acute respiratory illness and having been in contact with a confirmed or probable case of COVID-19 in the last 14 days prior to symptoms, or a patient with severe acute respiratory illness and in the absence of an alternate diagnosis that fully explains the clinical presentation. So based on this, we are now looking at a suspect case, a probable case who is a suspect case for whom the COVID-19 test is inconclusive or it's negative, and in a case for some reason the test could not be performed. A lab confirmed case is one who is a confirmed case is one whose lab tests are positive. It could be the rapid antigen test, it could be the RT-PCR or the CB-NAT. So as we look at our classification, it's slightly different from what is done as far as WHO is concerned, because very severe and severe is combined into one. So we have mild, moderate and severe. Around 85% of individuals will fall into the mild category, around 10 to 15 in the moderate, and less than 5% in the severe category. And this just gives you an overview of what we mean by mild. Moderate predominantly is those who have dyspnea, hypoxemia and have tachypnea, and those who go into severe respiratory distress with a significant fall in saturation or increase in respiratory rate, or go into septic shock come into the severe category. Our treatment strategy has evolved over the last 6 months for not really knowing what to do to really having these broad 4 pillars as far as treatment is concerned. Antivirals, and we're still not sure how effective a large number of antivirals are. Oxygen therapy, which I think is the backbone of treatment as far as treating patients with COVID-19 is concerned, and I won't talk about this much. Dr. Sushma Bhatnagar will cover this. Then anti-inflammatory, again a controversial area, the use of anticoagulants, and what really matters is supportive treatment. So if you look at antivirals, the drug which is now considered useful is remdesivir, which is basically the initial preliminary report which came out way back in May which was a double-blind randomized controlled trial of more than 1,000 patients, which looked at 10 days of remdesivir with the initial loading dose of 200 milligrams on day 1, did show that it was superior in shortening the time to recovery in adults hospitalized with COVID-19. It did not show any mortality benefit. Subsequently, based on number of other studies, the FDA gave a broadened emergency use authorization to include all hospitalized patients for treatment for COVID-19. Remember, in the early part, it was only for moderate to severe patients, patients who had fall in oxygen saturation, who had pulmonary infiltrates. But recently, around the end of August, the FDA actually changed its guidelines and said it could be given for all patients, including mild patients who were hospitalized for treatment of COVID-19. Also, last week, the final report was published which was the initial report from the Act 1 study, which again showed that 10 days remdesivir led to shortening time of recovery and improvement of the ordinal scale scores. There were fewer days of subsequent oxygen support in those already on oxygen. So again, there was no mortality benefit, but oxygen support came down and hospital stay came down as far as the group which received remdesivir. We still don't have hard evidence to say that this actually antiviral drug causes a mortality benefit. As far as the Ministry of Health and Family Welfare is concerned, it is advocated that it can be given for 5 days. There were studies which compared 10 days versus 5 days and showed that 5 days is equally effective. And of course, if you have raised liver enzymes, if your creatinine clearance is low, it should be avoided. And there is really no data as far as safety is concerned in pregnancy, lactating mothers and children less than 12 years of age. Then coming to hydroxychloroquine, a large number of studies have been there. Again, another drug which has been in controversy, and this is there were initial studies as far as hydroxychloroquine was concerned, a French trial which showed that it may be of benefit in decreasing the viral load, and in that study it was shown that if you combine this with azithromycin, it had a better effect in terms of decreasing viral load and recovery was concerned. Subsequent studies, including part of the recovery trial and the solidarity trial, did not really show an initial benefit, although the dose used in the solidarity trial was much higher than what we ordinarily give, and this drug was therefore not felt to be of much use. This is basically a nationwide observational study of around 8,000 patients, which was done in Belgium, and they found actually that in hospitalized patients in this study there was a mortality benefit. Let's say it was 17% in the hydroxychloroquine arm as compared to the control arm, and the hazard ratio was 0.68. So this actually study again did favor the use of hydroxychloroquine. However, a recent study published last week in NEJM, which looked at again hydroxychloroquine hospitalized patient with COVID-19, did not find any evidence to show that it decreased the incidence of death at 28 days as compared to usual care. So again, a drug which is still in controversy and not really a standard of care, or not really clear whether this is effective as far as an antiviral is concerned in COVID-19. Coming to convalescent plasma, there have been a large number of previous studies which looked at small number of patients, 5 to 8, published in JAMA and in PNS. They did tend to show some degree of benefit, but then subsequently in JAMA in June, this RCT came with about 103 patients, and this showed some improvement at day 28 in severe illness, but not in life-threatening illness. And again, this did not show a mortality benefit. However, the study had to be stopped early due to lack of participants and therefore was underpowered. Also, it did show that plasma therapy was safe. There was another study which looked at a large number of patients, and this again showed that there was a signal towards decrease in mortality. It also showed that plasma therapy could be safe. However, it looked at treatment of COVID-19 with high anti-receptor binding domain of IgG titers, convalescent plasma, and found that this is efficacious in early disease. So this study showed two things. One is that if you're using plasma which has high IgE antibodies, and if it's given early before an individual's antibodies are formed, then it may be useful. And there is FDA emergency use authorization for convalescent plasma in hospitalized patients. So this drug may be useful if given early and if the plasma has sufficient titers of IgG antibodies. Another study which looked at safety profile, and this showed that it was safe. This looked at a large number of patients, or 20,000 hospitalized patients, and found there was really no serious adverse effect as far as convalescent plasma was concerned. There is also a living systemic review of Cochrane, which has looked at convalescent plasma and hyperimmune immunoglobulins. However, this has really not been able to show benefit at 17 days, 7 days, 14 days, and 28 days. And therefore, we still need more evidence to say definitely that this is something which can make a big difference as far as treating COVID-19 is concerned. The Ministry of Health and Family Welfare recommends that it can be considered in patients with severe disease with increasing oxygen requirement despite the use of steroids. And you have to be careful as far as giving plasma is concerned. And one should really try and look at neutralizing antibodies titer in the plasma that one is giving. And normally around 200 ml is given over about 2 hours period. There's another passive immunity treatment strategy which is using monoclonal antibodies, which is under investigation. This is the Rigin-CoV2. It's become gone into interest has been risen because of that fact that it was recently given to the President of the United States. This is a combination of 2 monoclonal antibodies, and these are virus neutralizing antibodies. One of them binds non-competently to the critical receptor binding domain of the virus spike protein and therefore doesn't allow replication of the virus. This company in its press release has shown that this cocktail reduced viral levels and improved symptoms in non-hospitalized patients. It looked at a group of 275 patients who were randomized to high dose, low dose and placebo, and it showed that it rapidly reduced the viral loads to day 7 in seronegative patients. However, we still need to have a peer-reviewed article as far as this is concerned, and this is still an ongoing trial and currently has not really got any authorization in terms of being used as standard of care. Coming to the second arm, which is anti-inflammatory therapies, and I think it's important to remember that one treatment strategy which has actually shown benefit is steroids, and there was the recovery trial which showed that dexamethasone 6 milligrams a day for 10 days decreased mortality. The important thing to remember here is that it decreased mortality significantly in those who required ventilatory support and those who required oxygen. However, in those who did not require ventilatory support or did not need oxygen, it could possibly cause harm, and therefore it is indicated only for those who require oxygen or are having moderate to severe disease and needing needing ventilatory support. Number of other studies have been done, and there was a meta-analysis published by the WHO Rapid Evidence Appraisal Group, the REACT working group, which looked at number of studies, the DEXA-COVID studies, the CODEX study, the recovery trial, and the CAPE-COVID study, which looked at different drugs, dexamethasone, hydrocortisone, and methylprednisolone, and showed that this was a class effect rather than related to any drug. And there was a benefit shown in whether you use dexamethasone, hydrocortisone, or methylprednisolone. And this does tend to show that steroids definitely have a benefit as far as treating COVID-19 is concerned. And this is also recommended in the Ministry of Health and Family Welfare guidelines that we can give either methylprednisolone or dexamethasone. A low dose usually recommended for moderate disease, but a higher dose can be given for those who have more severe disease, whether it's methylprednisolone or dexamethasone. Coming to the other anti-inflammatory drug, which is again controversial to some extent, tocilizumab. It's an antagonist of the receptor IL-6 receptors. It inhibits IL-6 receptors by, and this actually leads to reduction in cytokine and acute phase reactant production. Initial studies, and there are 2 or 3 studies which came up in Lancet Rheumatology, which actually showed some benefit. This is one such study which came in August, which is a retrospective observational studies at 13 hospitals, looking at 630 patients, of which 210 received tocilizumab, and this showed an association was noticed between receiving tocilizumab and decreasing hospital-related mortality, suggesting that this did have a mortality benefit in those requiring ICU support. Subsequently, the Covacta study by Roche actually did not show any benefit, and they said that it did not meet its primary endpoint of improved clinical status in patients with COVID-19 associated pneumonia, or the secondary endpoint, which was reduced patient mortality. And this again sent this drug into a little bit of a controversy. There is also a meta-analysis of observational studies which was published in September, which looked at 10 observational studies and looked at IL-6 in terms of reducing mortality and increased side effects. This actually did tend to show that mortality was 12% lower for COVID-19 patients treated with tocilizumab compared to no tocilizumab, and there was not much of a difference as far as side effect was concerned. So again, some controversy. The third arm is basically anticoagulants, and SARS-CoV-2 is associated with inflammatory and prothrombotic state. We all know that. We know it leads to thromboembolic phenomena, especially in those in the ICU, and stroke has also been seen. And therefore, hospitalized patients should receive venous thromboembolism prophylaxis. What is the dose for how long is still not clear, and people at times look at the D-dimer to give you some idea, but there is still no clear-cut guidance in terms of the dose and duration. Studies which have been done report that around 20 that there is significant thromboembolic phenomena, and this risk is elevated despite the use of anticoagulant prophylaxis, but optimum dose is still not defined. Currently, what is recommended is that prophylactic unfractionated heparin or low molecular heparin should be considered for all patients who are hospitalized with moderate to severe COVID-19. And therapeutic dose can be given for those patients who have established DVT, pulmonary embolism. Even in those who are more sick in the ICU, one would tend to give a therapeutic dose as far as anticoagulants is concerned. The other experimental therapies include favipiravir, which is again approved by DCGI. It's a drug which was used for influenza, but has shown activities against other viruses, also the RNA viruses, and it's an oral therapy. Some studies show that it may have faster viral clearance. One study published in the Lancet looked at triple therapy of ribavirin, interferon beta, and lopinavir ritonavir, showing that this was superior to lopinavir ritonavir alone, but I don't think we have enough evidence of its utility. And we have one anti-IL-1 drug, anakinra, which is used in the US, not much used in India, again tending to show that it may have some beneficial effect. Itolizumab is another drug which is basically a humanized anti-CD6 monoclonal antibodies. A large body of literature is available. This is made by an Indian company, and the studies have been done mainly in Cuba, where it has been shown that it may be useful as far as severe IL-6 is concerned. Then we have IVIG, also some studies which show that IVIG may be useful in severe cases, and other drugs have been used which are actually TNF-alpha antagonists. Basically, what we need to look at is a treatment strategy, and I think this is the slide that is the most important as far as current treatment is concerned. We start off with the black line, the black wavy line showing how the disease progresses. Most of the patients stop at the first dotted line, where we have only stage 1 and symptomatic treatment is required. We could give hydroxychloroquine, some people give ivermectin, and some would also give favipiravir. Some patients, about 15%, move on to stage 2A and B, where you have decrease in the viral load but increase in the host response, and here drugs like corticosteroids, anticoagulants, remdesivir, and convalescent plasma can be given. Less than 5% will go into the cytokine release syndrome, and in these there is a hyperinflammation phase, and anti-IL-6 therapies or other drugs for inflammation can be given in these. So to conclude, and this is basically the treatment chart, which basically highlights the fact that patients who are having mild disease or moderate disease, once they recover and are asymptomatic for 3 days and it's been more than 10 days of illness, you don't really need to do an RT-PCR test before discharge. Therefore, to conclude, the current treatment of COVID-19 is primarily supportive. Antiviral and anti-inflammatory agents are promising agents for the pharmacotherapy of COVID-19, but I've shown you the controversy which has existed against all of them. The only drug which is actually useful is steroids. For mild disease, it's supportive care, possibly hydroxychloroquine in high-risk group, but again, this is a controversial thing. For moderate disease, remdesivir, corticosteroids, conscious proning, and of course, oxygen therapy, and plasma, convalescent plasma, which may be of some use. For severe disease, we again have corticosteroids, anti-IL-6 drugs, if there is a cytokine storm, non-invasive ventilation, and high-flow nasal cannula are very important. And in those who go into ARDS, ventilatory support, where we follow the ARDS network strategy for lung protective ventilation. As I've shown in the slide, appropriate timing of initiation is key to the successful outcome. So this is just to give you a broad overview. Thank you very much, and I will move on to the next part.
Thank you, sir. Thank you, Dr. Anant Mohan. Thank you, sir, for giving this opportunity to speak in the grand round of pulmonary medicine regarding severe COVID cases. I have made the title as Cure versus Care because the COVID-19 fight is on, and we are still not sure that what works best in the severe COVID cases. So next few slides, that how oxygen therapy works, and when should we really treat or should start thinking other way. So severe COVID disease basically defined as a patient who is having COVID positive by COVID RT-PCR or rapid antigen test with fever with features of pneumonia, respiratory rate more than 30, SpO2 is less than 90% on room air. That we will define as a severe disease. This is basically a flow diagram that how we have to go for the oxygen therapy in terms of oxygen therapy. So if patient is hypoxic and SpO2 is less than 92%, if there are indication for endotracheal intubation, means patient is hypoxemic, patient is unconscious, if there is a hypoxic encephalopathy, severely hemodynamically instability, definitely we should go for endotracheal intubation. If it is not and patient is tolerating supplemental oxygen by mask, definitely we should monitor closely, but definitely we should monitor closely for worsening, and we should not wait for more than 1 to 2 hours or if patient is deteriorating, we should not delay the intubation. If patient is not maintaining on oxygen, then we should definitely go for high flow nasal cannula, which is the most commonly used ventilator supportive measures all over the world. If not tolerating high flow nasal cannula or high flow nasal cannula is not available, then and there are indication of endotracheal intubation, we should not delay endotracheal intubation. But if patient is stable enough, then we should definitely try non-invasive positive pressure ventilation. However, we have to monitor closely at regular interval and monitor in the terms of patient should not deteriorate further, so we should not delay intubation in cases of worsening. While doing intubation, definitely we have to, because it's the most aerosol generating procedure, so appropriate PPE, minimum staffs, and most experienced person who knows the using of video laryngoscopy, definitely trained person should intubate, so that with the minimum staff we can manage and we can have a successful intubation. This is regarding high flow nasal cannula. It should be considered in selected group of patient when patient is awake, cooperative, and obviously with normal hemodynamics. When there is no urgent indication of intubation and PaCO2 is less than 45%. 40% or greater patient may still require intubation after having a trial of high flow nasal cannula. If no clinical improvement in 1 to 2 hours, definitely we should not delay intubation, because delaying intubation is not in favor of patient. And definitely it's a high potential for virus aerosolization, so we should have a PPE or protective equipment. All the personnel, healthcare staff should be in PPE. This is the systemic review of high flow nasal cannula. A lot of studies have come on as far as use of high flow nasal cannula is concerned, and conclusion is that it is a useful way of giving oxygen, but definitely we should not delay intubation, and it definitely decreases risk of invasive mechanical ventilation. The second method to give oxygen is non-invasive ventilation. This is basically continuous positive airway pressure or bi-level positive airway pressure delivered via tight fitting full mask, face mask. What we have seen that this basically is not, patient does not like it, and the patient feels suffocated. So definitely high flow nasal cannula always overweight, and most of the patients will end up in giving oxygen through high flow nasal cannula. Again, as far as if patient is not maintaining well, we should not delay intubation if we have offered non-invasive ventilation. In again, non-invasive ventilation can be delivered. It was a trial, and it was a lot of literature were coming on using of helmet. But what we have realized that using helmet, again, patient does not like. But definitely there is a less aerosolization. So it was a technique that it was favoring us, and people try to use it, but again the patient again it's not a patient friendly device, and patient does not like helmet because they feel claustrophobic. So ultimately high flow nasal cannula comes out to win on the top, and again, whether we are using non-invasive ventilation or high flow nasal cannula, intubation should not be delayed if required. Again, there are no clear-cut guidelines, clear-cut guidelines and policies in terms of COVID pneumonia is concerned, and whatever strategies we are using is based on the ARDS guidelines. And the most important and most favorable is lung protective ventilation, where the target tidal volume is 4 to 8 ml per kg in adult and children, ideal body weight. Target plateau pressure should be 30 or should be 30 and more there. And target SpO2 is in between. In between we should keep on 88 to 93%, and always we should use conservative fluid strategy. As far as if patient requires mechanical ventilation, we have to use high PEEP strategy, but definitely we have to keep a very close watch on barotrauma, because it's very common and patient fall into pneumothorax. Prone ventilation for 12 to 16 hours is very favorable for the patient. Intermittent bolus for should be given for with neuromuscular blocking agent, so that patient tolerates all these therapies well. And ECMO in selected group of patients in refractory hypoxemia can be used. This is again in prone positioning, awake prone position combined with high flow nasal cannula or conventional oxygen therapy has proved to be the most beneficial in a spontaneous breathing patient with severe COVID-19. And it has been seen that it avoids intubation, and as it improves mortality. Patient tolerate it well, and it decreases mortality. This is an article which was a review article published in Pulmonology, and it was a review article, and it says that basically again they are not inconclusive. In the conclusion they said that still everything is evolving, treatment is evolving, but definitely protection of healthcare workers should be paramount, and high flow nasal cannula with non-invasive ventilation and prone positioning is beneficial for the patient. As far as hemodynamics are concerned, we have to use conservative over the liberal fluid therapy. Crystalloids over colloids, again it will be depending on the patient's condition and individual choice. Buffered balanced crystalloids over unbalanced crystalloid will be the choice. Noradrenaline is the preferred vasoactive agent, and second vasopressor is vasopressin, which is second line agent used in this. Use of ultrasound is the most useful equipment or machine which is required with a patient with COVID-19 ICU. It rapidly detects pneumothorax, pleural fluid. It helps in pleural fluid drainage. It really helps in doing echocardiography, so that if patient is having pericardial effusion, we can detect. DVT immediately we can rule out, and intracranial hypertensions we can rule out. Now the multidisciplinary team decision will make as far as, because a lot of oxygen with the oxygen therapy, with antiviral, anti-inflammatory, it is still true that if a patient is critical and requiring invasive support, the mortality is very high. So whether we should think in terms of cure versus care. So there is a publication in Lancet with Lucas and Felicia. They have published, and what they have found that there is it is, again they said that it is not, there are no clear-cut guidelines, but best supportive care can be introduced for the following patient with a common consensus amongst treating clinical teams as well as family members. If there are common consensus amongst the treating teams and family members, then definitely we can. Again, they have in the bold they have said that it is not clear guidelines, but if patient is progressive chronic disease, if patient is old, frail with multiple comorbidities, but patient is having multi-organ failures, patient is in advanced cancer patient stage, with terminal stage of cancer patient, and end stage chronic disease, or any end stage chronic debilitating condition. So what we can offer in care pathway? We have to although if we are not going invasive mechanical ventilation or something, then we have to control symptoms, we have to provide adequate nursing care, we have to help in complex decision making, we have to communicate properly to the family members and to the patients and caretakers, and prognosticate them appropriately. And throughout the journey, we have to give them emotional and spiritual supports. And as far as we have seen that patients, those who are after death, we have to support if they are having some questions and they are feeling community. This is role of communication in patients, even if they are not critical or they are not. This is just again a publication from the NCI only, that even in the mild cases, people are requiring good communication or they need holistic care, because they are always almost more than 50% of patients, they remain worried, anxious, even if they are in mild stage. So it is very important, good communication, explaining about the disease. They are fearful, they think that if they have been diagnosed with COVID, they are going to die. So it is very important that we should take care of each and every patient in a holistic manner. This was after treatment. It was a questionnaire based stigma associated with COVID-19 patients, and what it has been found that almost 66% of patients, they are having a strong component of stigma, and we must address it carefully. And it is again with the good communication and explanation it can be treated. So oxygen therapy and all these therapy definitely works well in 80 to 90% of patient, but when patient is critical, it is sometimes we fail. But definitely our aim should remain that we will save lives, we will save our healthcare workers, we will save ourselves, and we have to keep moving because the fight is still. Thank you very much.
So good afternoon. I will be continuing the next part of the presentation. So this is data from the National Cancer Institute, which is the designated COVID hospital of one of the designated COVID centers of All India Institute of Medical Sciences. This is the NCI AIIMS register, which was designated COVID hospital in mid-March 2020, and subsequently we have been caring for COVID patients till date. Another view of the same hospital. So this is our screening and workup pro forma at admission. This was developed by residents and faculty and has actually been improved over time with input from residents as well as from various other healthcare workers. So this is what we do whenever a patient gets admitted. Our resident will fill this screening admission sheet, which will have all demographic details, including whether they are symptomatic or asymptomatic, whether they have comorbidities, when was the test done, whether they have availability of home isolation or not, which is important while we discharge the patient, and we decide and try and inform the patient provisional dates of discharge subsequently. This is how we have tried to work out a strategy where our residents have to do less of a job, so they can clerical jobs, so they can just tick and write details, and then they can actually concentrate more on patient care. So this documents symptoms in detail, various comorbidities that the patients might have, and the treatment that they are on for their background diseases. Subsequently, this is the chart on general examination, and we try and identify here whether the patients are at high risk of severe disease, on the basis of which we triage them onto a sicker ward versus a more stable ward, whether they have a decreased saturation of less than 94, which we have consistently used as a criteria for severe disease, mostly for the reason of triaging patients to HDU or ICU, and subsequently whether they have the severity of disease at baseline, again for triaging. This is our AIIMS screening admission sheet, this is how the resident is able to decide the patient's clinical status and where should they be admitted based on their initial screening. And this is the general treatment protocol, which enumerates all the basic usual treatments that most of our patients will be taking, and additional treatments can be written. So brief overview of admissions till date. This is the census data till today morning. So we had around 4,900 patients that we have admitted till date, out of which around 4,800 patients were COVID positive. The others were actually suspects who turned negative on subsequent report. Total discharges, so far we have discharged around 4,700 patients. We have lost around 50 patients. Currently 147 patients are still admitted, out of which 26 are critical or severe disease and are either in high dependency or intensive care units. So this is the data analysis. Subsequently, what I will be presenting is what we have analyzed for 4,219 patients. This is when we started. It was daily 5 to 10 patients used to come, and we used to think that the pandemic won't come. But then we had this first peak, which was when there was this rescue of patients, a lot of people from religious congregations, which actually led to our first peak. Subsequently, we had a decline, and then there was this gradual subsequent increase in patients over May, and end of May we had reached another peak of when we had around 400 to 450 patients on a particular day. Admitted on a particular day. Subsequently, that declined, and then again in first week of August we were under 100 patients for the first time in a long time, and then again we had this surge, third peak, which has actually somewhat continued till now. I'll show you the last 3-week data, which now shows that it is again decreasing. This basic demographic data for the patients we have admitted till now. So we have for the first 4,200 patients, we had around 140 patients who are of the pediatric age group, that is age of less than 12 years. Majority have been adolescents and adults, that is age from 12 to 60 years, that is around 3,800 patients. And then there have been more than 60-year patients who are 317, out of which around 100 patients who are more than 70 years of age. This is the gender distribution for included patients, and as is evident from worldwide data, it is the same, that is male predominance. Around 80% of patients who were admitted were males, and around 20% were females. There were around 4 patients who were actually transgender who were admitted on active screening. After active screening. This is the country-wise distribution of included patients. Initially, we had some patients who were foreign nationals, but most of them are Indian nationals. Coming to the comorbidities and risk characteristics, these are the smoking characteristics of the admitted patients. So around 2.5% each are current smokers and ex-smokers. Most of the patients, that is 95%, were never smokers. And the median smoking index of patients who were admitted with us was 100. Coming to comorbidities, as it is known to most of you, diabetes again is the most common comorbidity, followed by hypertension and CAD. We found around 2% of patients with hypothyroidism, and around 2.3% of our patients were immunocompromised due to either malignancy of solid organ malignancy or hematologic malignancy, that is 56 patients. HIV positive status, 32 patients, patients who are CKD, that is chronic kidney disease, who were on maintenance hemodialysis, around 13 patients, patients of rheumatologic diseases, around 13 who were on immunosuppression, and again post-renal transplant and chronic liver disease. Coming to symptoms, so out of around 4,200 patients, 55% of the patients were actually asymptomatic at admission and were admitted because either they had no home isolation, or in the initial phase of the pandemic, when it was mandatory to admit all the patients who were tested positive for COVID for first 10 to 17 days, or till RT-PCR turned negative 2 times. So out of these patients, fever again was the predominant symptom, which was there in around 750 patients, followed by upper respiratory tract symptoms, then cough and sputum. Around 7.7% patients had dyspnea. Most of these patients actually had severe disease. So again, I'm trying to highlight the fact that dyspnea is an important symptom to identify a patient at risk of severe disease. Then other patients had fatigue, myalgia, and other symptoms related to acute viral illness. Another important thing that we noticed was that around 1.5% patients had diarrhea, and out of these, around 48 had only diarrhea without any respiratory symptoms. So most of these were young patients with mild disease. So probably this is one subgroup which we should think about actually including in testing. Other complaints were other abdominal complaints, including chest pain, nausea, vomiting, abdominal pain, chest pain. Around 3% had headache, for which it was holocrania, for which there was no other apparent cause, no other upper respiratory tract involvement or hypoxemia, which could explain this. And around 2%, that is 80 patients, had loss of taste or smell. This could actually be underreported because initially in our screening pro forma, we had not included this symptom. Coming to severity, as you can see, most of the patients were non-severe disease, that is 92%, and around 340 patients, that is 8% of the admitted patients, had severe disease. The specific treatment received was initially azithromycin, and then subsequently doxycycline has been preferred for those patients who had mild disease but were presumed to be at risk of severe disease or had some symptoms to suggest concomitant bacterial infection. HCQS again was initially prescribed by most of us, but subsequently has actually we have stopped or decreased using it because we have better drugs now. For these patients that we have analyzed, around 50 had received remdesivir, 20 had received favipiravir. Around 410 patients had received systemic steroids because they had either a moderate disease or severe disease. Around 55 patients, that is 1.3% of our patients, received convalescent plasma because they had severe disease and were presumed to be in cytokine release syndrome at that time. 25 had received tocilizumab. 12 had received itolizumab, again as a part of therapy for cytokine release syndrome. 4 of the patients received IVIG, but this was basically 2 of the patients had immune-related complications. That is, one had immune-related thrombocytopenia related to COVID, and the second patient actually had Guillain-Barre syndrome, both of which actually responded to IVIG. The other 2 had severe ARDS and had contraindications to other immunosuppression. Overall mortality out of these 4,200 patients was 35, that is 0.83%. Most of the deaths actually were due to severe COVID ARDS. But important associated causes I would like to highlight that 5 of these patients we lost had active terminal malignancy. 3 had active TB and had come in ARDS, which was due to either disease. 3 had end-stage renal disease and subsequently had severe COVID ARDS. 3 patients had CLD, COVID ARDS, got intubated, and then we lost them. And 1 patient in our initial days, he was on HCQS and had a sudden cardiac death. Probably we attributed it to the drug. Then just some interesting data regarding COVID and TB co-infection. So this is for the first 28 patients that we analyzed. These patients were actually who were either diagnosed tuberculosis who developed COVID or actually presented and were diagnosed concomitantly with both the diseases. So out of these 28 patients, mean age was around 38 years. 25% had diabetes, 17% had hypertension, and 18% were immunocompromised because of various causes. 71% had pulmonary tuberculosis, whereas around 30% had extrapulmonary tuberculosis, and 85% of this was drug-sensitive tuberculosis, but around 15% had drug-resistant tuberculosis, and 40% were diagnosed almost together, that is within 3 to 4 days of each other. They were admitted with COVID positivity, and subsequently we worked up and found active tuberculosis. And around 17 patients developed COVID while they were on treatment for tuberculosis. Important thing to note is that out of these 28 patients, 8 had severe disease, that is 29%, and 12% mortality, which is much higher than when we look at overall cohort. 3 of the patients are still admitted with us. And again, this is the data on malignancies. We have so far we treated and had outcome for 56 patients with malignancies. 38 had solid organ malignancies and 18 had hematologic malignancies. And out of this 50 patients, that is around 90%, had non-severe disease, but 6 had severe disease. 4 required high-flow nasal cannula or oxygen support. 2 required NIV. Out of this, 1 required subsequent mechanical ventilation. And 5 of them, that is around 9%, we have lost. So far now, as I told you in the beginning, initially we had around 50 to 60 admissions in a day, and now it has started again reducing over end of September. Now again we have reached to around 10 to 12 admissions per day, and our census, that is today's total patients admitted, stands around 140 to 150. So it is declining, but we are continuing to treat our patients as we were. Now I would like to invite Dr. Saurabh Mittal to present the ongoing research that is going on at NCI.
Good afternoon. So now I'll be discussing about some of the important research projects which are going on and some of the published papers. So looking at the epidemiology of disease, as we have seen recent data, this was the first paper which was published from NCI on the 144 patients. Very initial experience of NCI while patients were being admitted in March-April month. Then regarding the pathogenesis of disease, this was the first paper which we published regarding the reason of TB infection and BCG vaccination and how it is affecting the occurrence of COVID-19. We looked at the available data on TB incidence and BCG coverage over the world in 174 countries. And what we found was that countries who had high TB incidence and high BCG coverage had a lower incidence of COVID-19. However, there were multiple problems in this analysis, that different testing strategies and ecological differences were there between the countries. which were not analyzed. Now, third paper, which is recently being accepted in Journal of Occupational and Environmental Medicine, is regarding the weather parameters and COVID-19. So in this, we try to look at the ambient temperature, humidity, and wind speed and occurrence of disease in Delhi. And during the study period of 97 days, there was a steady rise in the number of corona cases. If we look, the doubling time had positive correlation with temperature. That means as the temperature increased, the doubling time of the disease was increasing, while infectivity were decreasing, which shows that as we approach from March to June, there was number of the cases were rising, but the doubling time and the spread of disease was actually going down. Now, coming to the diagnostics of COVID-19, this was an institute-funded project on the intramural based upon the evaluation of a point-of-care rapid antibody test for the diagnosis of COVID-19, in which we included 132 patients, and they were sampled after 5 to 7 days of illness and 10 to 14 days regarding the presence of COVID antibodies by 3 different methods. The methods were, one was the rapid test kit bedside, another was Roche kit and the Siemens kit. And what we found that at day 5 to day 7, a small proportion of patients had antibodies which increased significantly on day 10 to day 14, and the Siemens machine was best detecting the IgG antibodies. And if we looked at whether asymptomatic or mild patient versus severe disease had any difference in the detection of antibody, only the rapid antibody kit had any difference, while rest all detected it same way. Now coming at the therapeutic trials in the management of COVID-19. So this is the first trial which started, was regarding the Mycobacterium W vaccine for severely ill patients in COVID-19, which is still going on. But the initial data which is available from CSIR, among the 42 patients, there was a significantly improvement in the ordinal scale patients who had less than 2 in the MW group as compared to the placebo group. But this study is still ongoing. Then there are 2 other trials which are ongoing regarding the MW for patients who are not critically ill, and another trial for patients who will receive MW with a placebo control, who are at risk, like the healthcare workers as well as the contacts of the patients who have COVID-19. Now coming to the ivermectin. So we started this DST funded project regarding randomized control trial of ivermectin in hospitalized patients. We included patients with non-severe, that is mild or moderate disease. In 3 arms, placebo, ivermectin of 12 mg and ivermectin of 24 mg, single dose, and patients were followed up. We have just completed this trial and efficacy data is being analyzed. The adverse effects were reported in 20, and all of them were mild side effects and no serious adverse event was noted. Another trial of pegylated interferon alpha 2b has recently been completed, in which we included 40 patients, and there was a significantly improved difference in clinical improvement in the interferon group as compared to the standard of care alone. Now coming to the prone positioning. So this was first case report which is under review, in which we reported that one patient who presented with hypoxemic respiratory failure had significant improvement at 30 minutes and 12 hours after the prone positioning. And this was a review which we published in Archivos de Bronchopneumologia regarding the awake proning and how can we have a protocol and positioning for the awake proning, in which we propose that how should we include the patients, how do we assess him, how do we continue to monitor, and when do we stop prone positioning for patients with COVID-19. This is a case control study which is currently under review, which is a prospective interventional study in which we have included COVID-19 subjects with hypoxemia, and the primary outcome in these patients was rate of intubation in patients who received prone proning versus who did not receive prone positioning, and total 45 subjects were included. Among these, 30 were cases and 15 were controls, and patients who received prone positioning had lesser requirement of mechanical ventilation as compared to those who did not receive. Similarly, their oxygenation parameters were better as compared to those who did not receive prone positioning. And this is one systematic review which we have completed on regarding the awake prone positioning for management of hypoxemia, and we found that in the entire 16 studies, 86% patients had improvement in hypoxemia once they given prone positioning. And this is one recently accepted letter regarding that how can CPAP make a difference in patients who are being given awake proning. because some application of PEEP versus a high flow nasal cannula may have a better effect in patients who are being given awake proning. There were two small letters regarding the steroid use in the COVID-19 and its effect on the diabetes. Now we coming to the international pulmonology services. So we were going through a lot of difficulties to reinitiate the bronchoscopy during the COVID-19 pandemic. And then we started developing ideas that how can we do about it. So we made this low cost tent-like structure where a hole is made for bronchoscopy, and that's how we started bronchoscopies in the COVID era. This is our experience of bronchoscopies during COVID era, which is under review. What we found importantly was that there was a drastic decrease in the number of bronchoscopies. Number of procedures which were done independently by residents had markedly reduced. The workforce required per procedure had increased markedly, and additional cost per procedure had also increased because of the use of PPE and pre-procedure COVID testing. And this is one patient where patient with COVID-19 who had lung collapse due to mucus plug, and he improved after a therapeutic bronchoscopy. Now coming to regarding the follow-up of these patients, there was initial guidelines that patients should be having a negative report before they can be discharged from the hospital. But what we found from the literature review that positivity on PCR does not necessarily translate to infectivity in the respiratory viral illnesses, and we need to look at better ways to identify when patient is infective and whether he is not. Regarding the prevention of COVID-19, so there is a trial of the Covishield vaccine which is about to start in the institute. Then we published a small letter regarding the face shield use when there was a report in the newspapers that in Bihar there were a lot of sampling being done without a face shield or without any PPE. So we wrote that probably use of face shield in such settings can actually help a lot of prevention in community healthcare workers. And we also reported regarding the acidosis in one of our residents who developed acidosis during IC duty while wearing a N95 mask. Some of the other publications which we have had, this was a comprehensive review on COVID-19, which was published in Expert Review, which is this was done in the initial part of the pandemic, and it really helped us looking at the disease and understand it. And this was regarding that how the training has been affected in patients in the times of COVID for residents. And there are a few more case reports and case series which are under review. So this is all about the research which is going on regarding the COVID-19. So now we'll go to the next talk by Dr. Anand Mohan on the post-COVID sequelae.
Thank you, Saurabh. And in the last leg of this grand round, basically after having gone through more than 6 months and thousands of patients to our hospital, now we are also getting to see more and more complications and sequelae of the acute infection. And now it is being increasingly recognized that post-COVID sequelae is in a way a new disease and entity per se, and we might be seeing more and more of these in the times to come. So a quick word on that and what is our experience with that. It's basically an unknown journey ahead, and because we do not really know the long-term complications, we only know the short-term complications and outcomes over the last 6-7 months of patients who have recovered, and we need to be aware of that. And if we now see, actually COVID-19 actually has become a kind of a systemic disease, and it has known to cause systemic complications affecting multiple organs. And as we can see right from the eyes, where the impairment of retinal vascularization, problems in the nose, as we know, smell disorders are already there, problems in the heart, cardiac problems are even a cause of mortality, causing inflammation, aggravating heart failures, in kidneys causing renal failures. Then vascular problems are known in the form of blood clots, endothelial dysfunction. It is an inflammatory disorder, and autoimmunity also forms a part of the pathogenesis. So there is increase in cytokines and autoantibody production. Among the muscles, we all know myalgia, myasthenia is a very important part of the symptomatology of this disease. And even later immobilization because of malnutrition, sarcopenia occurs, disability occurs. So these are all long-term complications that now we are seeing. Of course, the virus can infect the lower GI tract, and that is one of the common symptoms, as we had already seen. Also has effect on the liver, and as the lungs are of course the primary target, and we'll see what can be the etiology, the effects on the lungs. And there are certain neurological and psychiatric effects as well. If we talk about the symptoms after COVID, and it is not just, it's a very short-term kind of illness, the magnitude of the problem is pretty huge. And this was a paper which showed that when patients were assessed on a mean of almost 2 months after being diagnosed as COVID, after the first symptom, very few, in fact, almost 12 to 13% only were actually free of any COVID-related symptom. Most of them, many of them had at least 1 or 2 residual symptoms, and 55%, almost half, had at least 3 or more symptoms. And here we can see the commonest post-COVID symptom on follow-up remained fatigue. So they had fatigue for a long time, even after so-called clinical and microbiological recovery. Dyspnea was there, joint pain, chest pain. So a whole range of symptoms were still there even after 2 months of so-called recovery, including anosmia and others. So this is something to worry about, although they did not have any of the acute symptoms. Coming specifically to the pulmonary sequelae as such following COVID-19, and this is something, basically it can be symptomatic or it can be the physiological effects. And we look at the physiological effects over here. This was a small study of 77 patients, which out of which 55 were tested by CT scan. And among those who had normal CT scores, the pulmonary functions were abnormal in only 2. But on the other hand, all those who had abnormal CT score, pulmonary functions were abnormal in almost 1/3 of that, that is 12. So if the initial CT scans are abnormal, the chances are that in the long term, the residual physiological dysfunction will also be higher in the group of patients. And these were the abnormalities in almost 1/4 of the patients. Some or the other spirometric abnormalities were there, which were manifested in the form of low diffusion capacity of carbon monoxide, small airway dysfunction, low FEV1, FVC were there in about 10 to 11%, and also low total lung capacity. So these were some of the features which were there even after recovery, and this was 3 months after the recovery of these patients. And just a couple of slides to show some of our patients who had, these were the initial slides. As you can see, the initial x-ray of these patients showing consolidation, almost extensive consolidation throughout. At 6 weeks, although much of that has resolved, but still you can see the fibrotic areas in bilateral parts of the lungs is there. So it is not as though it has completely resolved. And this is the CT at the 6 week time, and you can see some background ground glasses also visible that may signify some active infection, but definitely underlying fibrotic disease is also there at that point of time. So this is also at 6 weeks after the initial diagnosis. Another patient, this was the initial x-ray at diagnosis, and then again at 4 weeks. So most of it has improved, most of the acute part has improved, but we can see the fibrotic strands and other fibrotic areas also still persisting. And this is the CT of that patient. Again, we can see some fibrotic areas, some atelectatic areas are still there after 1 month of the disease. Also, post-COVID pulmonary thromboembolism has been well reported, and this over here we can see, and in one of the segmental branches of the pulmonary artery, we can see the clot. So this is also one important long-term complication that may have future kind of morbidity and mortality implications also that one needs to keep in mind. What are the risk factors for pulmonary fibrosis? We are still not very sure, but whatever studies have seen, older age, severe illness, longer length of ICU stay, and need for mechanical ventilation, smoking, and alcoholism are some of the risk factors. So a very common question now that comes up among the clinicians who are treating, what is the radiological course? When should we do a repeat follow-up imaging? Is this fibrosis permanent, or should we give something? So these are some of the many questions which have come up. And to answer some of that, this retrospective review of a CT scan was performed at discharge after 2 weeks and after 4 weeks. And they showed that focal ground glass opacities reduced, multiple ground glass also reduced, consolidation, interlobular septal thickening, subpleural. So all these features actually reduced significantly from discharge till 4 weeks. Although they did not actually go down to 0%, they were still there, but there was significant improvement. The lung lesions, around 1/4 of the patients were fully recovered after discharge, and again it increased to up to 65% after the second follow-up. So improvement is there, although it may not be absolute. Post-COVID, the lung damage could be reversible. That is one message that we want to give, but still we do not know what is the optimum timing as to when we should do follow-up scans. probably it is prudent to wait for at least 4 to 6 weeks minimum. That is what is the general opinion as of now, maybe even slightly longer, before a follow-up scan is done, to actually say that now the things are basically irreversible, because initial part may be because of the infection. Hence, the question comes as to the role of antifibrotics. Again, we don't know the answer to this. We have two antifibrotics, pirfenidone and nintedanib, and they have been used in combination with anti-inflammatory agents now as more and more post-COVID pulmonary fibrosis is coming up. I won't go into the the mechanism of action, but these are the two which are probably under trial. Now, even lung transplant has been done for post-COVID extensive fibrosis and respiratory failure, but it must be kept in mind that many patients are not really candidates for this particular kind of modality. Hence, it is considered in a very selected group of patients who have extensive ARDS, fibrosis, irreversible respiratory failure. Ultimate effect of this still remains unknown. Although we have a procedure performed in our country as well, and this was at a private hospital in Chennai where a lung transplant was successfully carried out. So probably more and more such things will happen, but we have to see how is the patient selection going to be done. Quickly going through other manifestations of the post-COVID sequelae. Cardiac manifestations are well known, cause acute coronary syndrome, arrhythmias, thromboembolism, myocarditis, and heart failure or cardiogenic shock may occur. And this was just one paper showing that acute heart failure in COVID had a higher mortality. Some vascular complications, we know that it may predispose to venous and arterial thromboembolism, and this study on 184 ICU patients showed that there was a high cumulative incidence of vascular phenomenon of almost up to 31%, with pulmonary embolism being the most frequent. Another new entity of post-intensive care syndrome has also now come up, because more and more patients who are coming out of the ICU, they are basically severe COVID patients who are complicated by respiratory failure and other multi-organ failures, needing a lot of ICU admission with probably mechanical ventilation. So this is defined as a new or worsening cognitive, psychiatric or physical functioning after a critical illness that has occurred in them. Last 2-3 slides of rehabilitation. So how do we treat these patients? As of now, we don't have any particular medication. That will have to be based upon their symptoms, but impairments are most likely to encounter the problems which may occur as physical deconditioning, muscle weakness and fatigue, impairment of lung function we have already seen, delirium, cognitive impairments and mental health disorders. So again, a multidisciplinary team approach is necessary. And basically, we need to address the consequences of ventilatory support and prolonged immobilization. Probably these are the two most important factors that we have to address so that they don't cause complications. Any role of inhaled corticosteroid? Not really as of now. This was also a question that came up. There were some in vitro studies of cyclophosphamide and budesonide, but they have not really had any conclusive evidence. When should we call the patient back and what should we do? Telemedicine is now coming up in a big way for all these patients, probably within 1 month, then again at every 2 to 3 months, and then at 6 months would be a reasonable time for follow-up. Do a post-ICU care with a multi-speciality kind of a approach and start rehabilitation and nutritional support as soon as possible. So with all this background, we'll conclude that COVID-19 remains a multi-system disease, not just something limited to just one organ as we see after 7 to 8 months of this pandemic. The degree of organ involvement, the timing and the severity are pretty variable. The management also, unfortunately, is not very much standardized. The prognostic factors are not clearly elucidated. Also, unfortunately, late manifestations are now becoming more and more common. And hence, to prevent and to manage them, a regular multidisciplinary follow-up and a screening protocol is extremely important and should be in place everywhere for early detection of long-term complications. With that, I'd like to thank you for a patient hearing, and I'd like to acknowledge all our patients whom we have seen, all the staff on COVID duty who have been doing repeated rotations day and night, various departments, especially Department of Onco-Anesthesia, Palliative Medicine, the hospital administration, anesthesia, critical care, medicine and all the allied specialties, the laboratory, microbiology, lab medicine and the lab oncology, and all others who have been involved in this, and all my departmental faculty and all my fellows who have been also working day and night. Thank you very much.